Good afternoon. Welcome to another episode of Healthy Chicago podcast. My name is Christian Zamarriego. I'm a projects administrator at in CDPH in the Behavioral Health Bureau, where I have the honor and the privilege to work with several Chicago-based community organizations across our mental health and substance use funding portfolio. Today I'm really excited to talk about one of those programs, shelter-based care. In a nutshell, shelter-based care is a CDPH-funded program that partners with Lawndale Christian Health Center to provide health care, substance use treatment, and mental health services to individuals experiencing homelessness across shelters and drop-in centers in the city of Chicago. And here with me today to highlight this work and go a little bit more in detail about it is Tom Huggett, Dr. Tom Huggett, Medical Director for Mobile Health for Lawndale Christian Health Center. So thank you for joining me today.
Well, gosh, thanks. Honored to be here.
Yeah, absolutely. So why don't we start by just introducing yourself, telling us a little bit about, the work that you do and potentially like what led you to this work.
Sure. Well, I'm a farm boy from Wisconsin, and I had my education at University of Wisconsin and medical school here in Chicago at University of Chicago. And I did a Master of Public Health at Johns Hopkins. And now I live in the Austin community for the last 22 years, Austin community of Chicago. And I'm really blessed and privileged to lead a group of about 55 folks who serve folks in about 30 shelters throughout the city of Chicago, soon to be 43, as you know. And so we're really, and I've done this work for about 30 years. I've worked with folks experiencing homelessness and providing medical care as a family doctor. So I'm trained as a family doctor, and I see patients. I saw patients yesterday. I saw patients on Monday, and part of the team that does that type of work.
It's wonderful. Wonderful. Thanks for sharing. And I gave a one-sentence description of shelter-based care. Can you go a little bit more in depth of exactly what is shelter-based care for those who might not know?
Sure. Healthcare for persons experiencing homelessness became kind of a special niche for folks who are not really being served by traditional medical care. So the federal government set up what became the McKinney-Vento Act in 1987. And so there are programs in 300 community health centers throughout the United States serving about 900,000 people experiencing homelessness throughout the United States and territories. So that's part of what we do. Shelter-based care means that we're bringing care to people that are currently residing in shelters, providing shelter for folks experiencing homelessness. So we bring our medical team into the shelter and bring that care to them in that type of a setting. People kind of say, well, why do you do this? Mm-hmm. And part of the reason is that the traditional setting sometimes doesn't work. I can give you an example. There's one shelter in East Garfield Park that is just a half a block away from one of our clinics. And somebody say, well, why don't folks just walk down a half a block to the clinic and mm-hmm. be seen there? But there are lots of obstacles sometimes that people encounter. And sometimes we really need to bring services directly on site to folks in the shelters. Sometimes there are difficulties with appointments. I think one thing that when I'm talking with students that I say is that healthcare for folks experiencing homelessness is about number 7 on the list of things that they're working on. Mm-hmm. They're working on housing. They're working on jobs. They're working on clothing. They're working on trying to get food. They're working on getting their kids into school. They may have some legal issues. So healthcare, even though it's very, very important for folks experiencing homelessness, kind of drops down on the list. Right. And shelter-based care really expands access to the services that they really need. Mm-hmm. So that's why we bring the services to folks within the shelter setting.
That's wonderful. It's like a strategy that meets people where they're at. And
right.
Identifying barriers, right?
That's
barriers
right.
That to most folks might not seem like a barrier, but even if it is a matter of going down a block or two, there's something.
Yes.
There's something unique about bringing the services to the shelters where people are residing.
Right. I think that's what we've found again and again, and making that personal connection within the shelter setting where folks are sleeping that particular night really is impactful.
Yeah, absolutely. And I want to talk a little bit about shelter-based care in terms of a public health strategy. Can you speak to why you believe shelter-based care is an effective public health strategy?
Sure. I'm just reflecting on Chicago Department of Public Health's own publication. I mean, you guys put the commissioner and Commissioner Dr. Ige and your team put together the Healthy Chicago 2025 strategic plan. And what that really identified was a couple of things, and that there's a disparity in life expectancy between blacks and non-blacks of 11.4 years. So that life expectancy is something that needs to be addressed. The state of Illinois put out a morbidity and mortality report, which showed that there is a 17.9-year discrepancy between folks who are experiencing homelessness and people who are housed. 75% of persons experiencing homelessness in Chicago are black. So by serving folks experiencing homelessness and really focusing on addressing the needs that they have will help in the strategy that the city has laid forward, and Chicago Department of Public Health in particular has laid forward to try to address the equity issues. How can we provide? How can we close that gap between black and non-black, and folks experiencing homelessness and folks who are housed? How can we close that gap so life expectancy can be more equivalent, more equitable?
Yeah, I mean, now we're talking about, some type of like a compounded inequality here that's operating,
Yes.
right? Like the Healthy Chicago, 2025 strategy talks about addressing those 11 years, right? Which is really key. And I think part of that strategy is funding and supporting programs, right, that are directly addressing some of the key drivers that are driving that expectancy gap. And I think shelter-based care does a wonderful job at touching base on 3 of those. There's 7 key, like programmatic.
Yes.
Yeah. And it's mental health, substance use, and then addressing chronic diseases, right? And shelter-based care, it encompasses all 3 of these services. But then we're adding and talking about kind of a layer of homelessness here, where a new study is showing, the life expectancy gap is 17 years, right?
Yeah, right.
So I think that just highlights how important this work is for just Chicagoans experiencing homelessness and the disparities that exist within that population.
Yeah, I really totally agree. And to I think that in addition to what you said in terms of chronic disease, high blood pressure, diabetes, the risk for stroke, substance use disorders, people who are, still struggling with the use of heroin, mental illness issues, people who are struggling with schizophrenia or bipolar disorder or, perhaps even depression. What we can add to those are the things that, we really learned through the pandemic is that being on site, having a healthcare team on site within a shelter also helps with infection control. So infection control is also one of the focus areas in this strategic plan. And so our team was very involved with helping out with isolation, infection control, immunization. That, I'm so grateful that the Chicago Department of Public Health prioritized persons experiencing homelessness to receive some of the first COVID vaccines, when they came out in 2021. So infection control is also part of it. And I also really kind of also focus on the infant mortality rate, too. So there are plenty of families and plenty of women who are pregnant that are experiencing homelessness. So we want to make sure that they are linked to care. This was particularly important for the folks who were new arrivals, especially many of the folks that were bused from Texas.
Which you also had an involvement with as well, correct?
Absolutely. So we were very involved with, the thousands of people, the 50,000 people that came to Chicago, and thousands, as you know, were in our shelter settings. And there's a special effort for folks who are pregnant, and to make sure that they were linked to the care that they needed to make sure that that we could really effectively address those disparities in terms of infant mortality and maternal mortality.
Yeah, our conversation is surrounded about the work that you do that falls within kind of the scope of work that, I'm involved in within the Behavioral Health Bureau. But to your point, you've also worked with different bureaus within CDPH and other government entities. I know you've collaborated with, the state around, the whole shelter system and the response to the influx of migrants that we had. And so you've been really plugged in a lot of areas. Yeah.
Right. And one thing I wanted to say that was particularly I really liked in the strategic plan is it was talking about housing first and not housing only.
Right.
So to me, that is really, really key and very insightful part of the strategic plan. Talking about helping people into housing is very important. But I think we both know in working, we worked closely together through accelerating moving events and other things, trying to move folks from the shelter setting into their own home, that certain supports will increase the amount of success that they have of maintaining their housing. So I think that, working with behavioral health care providers or other types of healthcare providers that say, this person will maximize their success if certain supports are there,
right,
then, that's going to be a win-win. So housing first, yes, but not only housing.
Right.
We really need to address those supports.
Right. Yeah, what are the supports that are embedded that make the transition to housing successful, right? Housing being a key determinant of health is obviously really important. And I think that's what's driving housing first philosophy.
Yes.
But we see this other side of the work where the folks that we're working with who transition into housing, if they transition without the appropriate support or that linkage to care, there's a high probability that they will re-enter homelessness.
That's exactly right.
And as you're speaking, I'm thinking, I think this is the importance of working towards de-siloing, right? A lot of different providers in this space. Mm-hmm. And we've worked closely together where, in my previous role, I was a director of a homeless outreach program. And the folks that our outreach teams would help transition from shelter into housing, what made that transition successful when they were successful was remaining linked to the care that your team was providing.
Yes.
And I think that's an important part, right? Is like the care that you're providing isn't necessarily within those four walls of the shelter, but it's such that it's also providing services, whenever the person is transitioning out. And if there is, a support team that can continue and help facilitate that linkage so the person can continue in care and to meet their goals, working on their mental health,
right,
or their substance use, or just their overall health.
Right. So I think it's part of those supports. What makes taking care of folks experiencing homelessness that are in a shelter from traditional medical care. That was one of the things that's kind of what you were pointing toward. And some of those may not be so obvious to some folks, but like transportation is a big, big issue for folks. So how do you get to appointments? How do you get to the pharmacy to get your medications? Accompaniment. Some folks have difficulties getting to appointments. Mm-hmm. And so we have some folks in our staff who actually can accompany a person to their appointments. That can be huge. Assisting with benefits, assisting with their medical insurance, making sure it's still intact. I saw a patient that gave me a call yesterday, and I had seen them for a prescription for their medication for their opioid use disorder for buprenorphine, and they said, "Oh, the pharmacy told me I couldn't pick it up. They said my insurance wasn't working." So then I talked with our care manager. Our care manager said, "Oh, well, his insurance is working. He just needs to sign up for the managed care organization again." So he had the Medicaid, but he didn't have the managed care organization. So we were able to sort that out. So those supportive services are so important, or otherwise people don't get the medications that they need to be successful.
Absolutely. I kind of want to somewhat back up a little bit and help maybe level set. We were talking a lot about the services that you provide, just broadly speaking. We have mental health, substance use, and like primary care. Mm-hmm. Can you speak a little bit into what exactly are those services? How are the teams providing these services, and what do they look like for someone who is receiving them? Right.
So we're very patient focused. So folks come to us and they don't have an appointment. It's kind of by walk-in. It's kind of by triage. So if somebody has something that's more important, according to the folks that we're seeing, we're going to need to push them to the front of the line. For example, if they really need wound care, for example. So wound care is definitely something that we deal with. We deal with refills of medications. We see a lot of folks who need their high blood pressure medication or their diabetes medication, the medication to prevent seizures or from an asthma attack. So very important. And then part of what we also do, I do a lot of foot care. I trim a lot of calluses. I trim a lot of toenails. And people really appreciate that. People may not think, well, that's kind of a funny thing to do and maybe not essential, but it really is essential if people are on their feet all day. If they're on the streets walking all the time, it's really amazing how we can do the foot care and people can be about their business. While we're doing some of those other traditionally more medical things, we also do quite a few screenings. We ask about smoking. We were looking at smoking and cardiovascular disease. Smoking is a big contributor for heart attacks and strokes, for example. And in the report, it was looking at certain high-risk communities on the west side and also on the south side. And smoking rates were higher than the general population, like 16 to 27%. But we did a study, and almost 80% of folks experiencing homelessness are smoking. And so what we really need to do is, how do we decrease their cardiovascular risk? How do we impact that gap, right? How can we impact that? We ask about smoking. We help with nicotine patches. We encourage cessation, nicotine lozenges, kind of like cough drops, to help to decrease the urge to smoke. We also screen for substance use, and we also screen for serious mental illness. So that's kind of how we kind of work when we're working with folks. Sometimes the medical thing can lead to actually the more important thing for their overall health, which may be their substance use or their severe mental illness.
Right. And so in addition to screening, so someone is, self-reporting or answers a certain way, the results of the screening tool, how is that person then triaged into further services?
So what we've kind of learned, I work as a family doctor. I'm not an addiction specialist. I'm not a psychiatrist. But I've learned that has to be part of my primary care if I am taking care of persons experiencing homelessness. So we are able to react relatively quickly. For example, we are able, if a person needs their medications for diabetes, high blood pressure, we can actually dispense it out of our suitcase or out of our cabinet right then and there. Right. If they have a sexually transmitted disease, we can give the medication right there. We did a study, and half the people did not make it to the clinic for their treatment of their sexually transmitted infection. We have to treat right then and there. And the same thing for opioid use disorder. If a person says, I want to do something, I can see something better in my life, I can see a better future for myself. We're very focused on goals and progress to those goals. How can we help a person get to their goals? So what we kind of say is, let's talk about your options for treatment. Is buprenorphine an option for you? What have you tried in the past? Have you used methadone in the past? What are those options that can help you get to your goals? And the same thing for serious mental illness. We can start a person on medications right away. And one other thing that I'd like to add just at the end here is that we also use higher levels of technology, that people may not expect. What does that mean? That means it's kind of like preferential option for the poor that you may have heard from Gustavo Gutierrez or Paul Farmer. They're saying that diseases preferentially attack the poor or the persons experiencing homelessness. So we have to be preferentially very active about what we offer folks experiencing homelessness. So we should use long-acting injectables. We should use long-acting injectables for folks who have a psychotic disorder. We should use long-acting injectables for people who have substance use disorder because we know that people have better success with those types of medications.
Yeah, absolutely. You're really speaking to something that I think is really key to this service delivery model here, as you're talking about the array of services that are gonna, that are being offered to folks. And one thing that is so important is the ability, and I think effective, is the ability to provide it in the moment.
Yes.
Right. I think our medical system in general is one that is fairly delayed. You make an appointment with the doctor. A couple weeks later, you might get seen. You get some blood work done. That might take a couple of weeks. That just does not work for the folks that you're working with.
Right. I mean, I remember you bringing me patients,
Oh,
right?
I would, yes,
From the streets, right?
I'd give you a call and say, I found this person that I've been looking for like 4 months.
Right.
They need an LAI. Can you see them? And then we would make it work.
Right.
And the story like the way that a person's life can be turned around.
Oh,
right.
Absolutely.
By having, kind of like a pathway to access care.
Yes.
Immediately.
Yes.
Like seizing the opportunity,
Yeah.
and for service providers, I think, especially working with people experiencing homelessness, like that is so important, is to just seize the moment of an opportunity when someone is willing to change or, is in that kind of, stage of change.
Yeah.
So,
Yeah, absolutely. I totally agree.
Yeah. Let's talk a little bit about last year's numbers. So kind of want to give our audience a little bit of an idea of what we're talking about in terms of the services that are being provided across our shelter system. So last year in 2024, the program had a total of 12,271 visits. This doesn't necessarily mean that they're unduplicated. It just means that that's how many visits occurred across the shelter-based care program. 10,835 of those were primary care visits. 847 were behavioral health visits related to, mental health support, and 589 were specific to substance use disorder treatment. Can you share some key outcomes or success metrics from the past year, and what do those numbers mean in terms of impact?
Yeah. We ran the numbers too, Christian, and we got slightly higher numbers, actually. So you're right, about 12,000 people, and that were 12,000 visits for about 4,100 patients. So we saw about 4,100 people in 12,000 visits.
Unique individuals.
4,100 unique individuals. And of that 12,000, about 1,100 were by behavioral health care providers, psychiatrists, and double that was behavioral health by the primary care. So 12,000, 1,100, 1,200, something like that. So I guess the bottom line is that the substance use disorder treatment and the behavioral health treatment is really a big part of what we do in primary care. I think that's kind of the bottom line. 3/4 of the people were also screened for tobacco use, and given medication. So that's a huge outcome for us. So if we really want to do anything for cardiovascular risk, it is that. Is what can we do to decrease smoking, and so that's really an important part of it for us.
That's interesting. Can you speak a little bit to like the success of any like smoking cessation efforts that you've all had?
We've done this for years. We had somebody who'd volunteered at one of our shelters and was counseling people one-on-one. But I think that what we really do is want to link the smoking cessation to a person's goals. Oh, I'm feeling short of breath, the doc just told me I have COPD, chronic obstructive pulmonary disease. I don't want to go on oxygen. So all of these different types of things. How can we link? I keep on getting colds all the time. How can we link, stopping smoking with a person's goals? And so that is how we're a little bit more effective. If we can link it's harder to get over your upper respiratory infection if you're smoking. If you stop smoking, then you'll have a better chance of getting over it, and you won't get it so often. You'll get over, your allergies won't affect you so much if you stop smoking, for example. So we really try to link it and make it as individual as possible.
Right.
And that's how we can kind of increase, rather than saying, you need to stop smoking. You have to take a patch, So we really try to link it to a person's goals.
That makes sense. It's like effective reframing, it seems like. I'm having this uncomfortable feeling or this experience that I want to get rid of, and then helping the individual kind of draw that line between, is the smoking potentially exacerbating and causing this?
Yeah, exactly.
Absolutely.
Right.
So we've been sharing, kind of woven in and out of our conversations, we've been talking about little like examples of what we're talking about. Can you provide just like a brief, maybe like a narrative, like a succinct like example of like a success story, something that that you have found very moving in this line of work?
Yeah, I one thing that springs to mind immediately is I'll call him Mr. R. Mr. R. I was seeing even before the pandemic in and out of shelter settings, living in abandoned buildings, really struggling with substance use disorder, with heroin that he had been using for 20 or 25 years on the West Side. Just snorting heroin, not injecting. But he was really struggling because he knew that he had goals of getting back together with his family, and this was interfering with that goal. So he came to see us, and we started, we talked about his options, started buprenorphine, and it was a start and stop type of a thing. There was some success, and then he resumed use. And I think that's one thing that we always have to remember, is that people sometimes go through a cycle, several cycles. So one failure doesn't mean that it's a failure, right, in a person's eyes. It's a learning. Like, what can we learn from that? That's how we kind of tried to frame that. He eventually went into several recovery-type programs, and then he was able to maintain and go into remission from his substance use. And then he went into his own housing.
Oh,
and then he was talking with me, and I said, well, what is your goal? And he said, well, I really need a truck, because he was a body mechanic, and he would like to have his own truck and be able to go see his family. So I asked him the next time, well, how are you going on your goal? And he said, I got my truck. He showed me a picture on his phone. And now he is now 6.5 years without using. And now he's actually an outreach person. So he is going up and down the Pulaski corridor where people are struggling with heroin and fentanyl, and he knows people who have died of overdoses. His colleagues have died of overdoses, but now he's reaching out to them. He is a peer to them, and bringing folks to us to say, maybe this is an option for you. So this is, and we've given talks together, we've given presentations together.
That's wonderful.
And it's really kind of, for me, it's really inspirational. And he is reunited with his family. He's driven to Mississippi and gone to a family reunion, is still taking buprenorphine because it helps him. Wow. And so I think that those types of stories are just so inspirational to me. And also, it's not just us. It's inspirational to the colleagues that he is seeing really on the streets.
Right.
And people see him and say, oh, I remember back in the day when you were such and such, and now you have your own truck. Now you're going to Mississippi. That's the kind of life that I want. So he can be an inspiration to other folks.
Right, and that's the wonderful part of that story, is the way that this person was able to turn their life around in a way that is now giving back to the community, right?
Right.
And for people to kind of people to see that distinction of like, wow, I remember it's
kind of like the 12th step, in the 12th step programs, is how to give back. Oscar Romero said this, and I'm going to look at it so I can say it the right way. There are many things that can only be seen through eyes that have cried.
It's beautiful, yeah.
It's beautiful, right? So that's the power of peers. That's the power of somebody who's been through something, to be able to say, hey, there's hope for you too. I have hope for you. If you have something, if there's something that you'd like to achieve, there's hope.
Yeah, which I think is, it's encouraging, because I guess maybe speaking to the Chicago landscape specifically,
yes,
we're seeing more and more kind of this call to have peers embedded in the teams and the work that we're doing, right? Because there is this kind of like advantageous like stamp or this experience that one can relate to that makes that person's work just so unique and impactful in ways that someone who doesn't have that lived experience, obviously plays an important role. It's like it takes a village, as they say, but like the peer work is like, I think something that we need to consider, like continue to lift.
Right. I totally agree. And the other part of the peer work that I have also seen is this idea. We can have all these programs. We can have all these services. But part of it is loving, Part of it is, loving in a practical way. How do you actually do that, Gregory Boyle has this quote, how do we cherish people? And he defines cherish as loved with your sleeves rolled up. Mm. I love that, because that really says, what's the practical thing that I can do for you today?
Like action-oriented.
Action-oriented. Mm-hmm. How can we work together? What do you want to work on to kind of move forward toward your goals? Mm. What are those cherishing things? How can we give a dose of cherishing to everybody give them how can we do in a very genuine way, right? Not in a fakey way. But how can we help somebody? I was, this is kind of goes into that a little bit because our team, I had a guy at one of our shelters that I saw yesterday, and he was having problems getting an appointment to see a lung doctor. I mean, he has COPD, he needs to be seen, he's gotten all the tests, his phone is working, but nobody's calling him back. We made 5 phone calls. 5 phone calls, and at the end of that phone call, they said, oh, well, we don't take your insurance anyway. So, but he knew that we were on his side. He knew that we were advocating for him. So I think that's part of being, that's part of cherishing somebody, is being on their side, being an advocate, trying to move things forward.
Right. That's you bring up a really good point, the advocacy piece, right?
Yeah.
I think you're talking a lot about, we're discussing, the work that I'd say that you're providing, that you're in control of, if you will. Mm-hmm. There's a piece to, all of this where like making those 5 phone calls and then there being an insurance issue that requires a lot of advocacy. What are some other challenges that your team faces doing this work?
Yeah, I think one of them is information exchange. So if a person goes to an emergency room or another hospital, we don't always have access to the information. And our patients expect us to have the information. They said, can you tell me what the results were in the emergency room? Because many times they're not even told the results. So they rely on us to interpret what the results were. And so trying to get that information, it's a bit better now because we changed electronic medical records, so we were able to access some. But I think information exchange is a big challenge. I think that just the stress of what may be happening with Medicaid. I think I had a patient ask me, was I cut off of everything now?
Right.
And no, he's not been cut off. But hearing the news, it kind of sounds like everybody is going to be cut off if they have Medicaid through expanded Medicaid through Affordable Care Act. So I think that there's a ton of stress that's out there just related to that, and just kind of trying to say, we're going to keep on working with you. No matter what happens, we're going to be here for you. We're going to be advocating. We're going to be working together to try to get what you need in some sort of way. I mean, we did it before the Affordable Care Act.
Right.
So we can, let's figure it out, Of course, we want folks to have access to insurance. And of course, we're going to advocate like crazy to make sure that is there for them. But we can still work it out. We're still going to be there with you.
Yeah, that's wonderful. You mentioned some of the challenges of information exchange. Can you, for the audience, maybe describe? I presumably hear some of the difficulties, at least from like my perspective and working alongside you, has been that like sometimes people who enter the shelter system, there's just not much information that either they disclose by choice or by, for any other reasons. And so providing healthcare, any type of services with like minimal history is really challenging. What are your thoughts on, like, would you say that that's accurate in terms of like the limitations of not having like a robust information exchange like network? What are some other ways that like limited information is impacting the work that you're able to do?
Yeah, I can give an example, and also how sometimes the traditional system doesn't work for people. I had a patient that was hospitalized for what we call altered mental status, or he wasn't thinking right. He couldn't put things together. It turns out that he had pneumonia, and that was part of it. As part of his trying to figure out, of course, they did a CAT scan of his brain, and they found a small tumor there. And it's probably benign, but he doesn't remember anybody telling him about that. And so he was very upset about that, rightly so. And it was only when we actually tried to get those records that we were able to talk about that and what the next steps were going to be. So that information, and that wouldn't not he didn't know about it, so he would not even be able to tell me about it. And he expects, the vast majority of folks expect us to have the information, right. And so we have to get consent. We always get consent when we say, "Oh, do you mind if I see what happened at such and such a hospital?" We always get that type of a consent, but the vast majority say, "Well, of course," So I think that we really need to make clear to folks that, folks really want us to work together with them and to use the testing that's already been done. Why redo a CAT scan of their head if it's already been done? For example, it can really save costs and can really get things done more quickly.
Yeah, thanks for that. Yeah. Kind of wrapping up a little bit here, I want to maybe look ahead with you.
Yeah.
Right. With shelter-based care, what do you think is, truthfully, I don't know how other, cities or states implement their own shelter-based care system. I'm assuming there's versions of what we're doing here. But in terms of within Chicago, how do you see this model evolving or improving in the future?
Yeah, I think a couple of things come to mind. One is respite care. So there are folks who are in the shelter who need a lot more care than we can provide in shelters. For wound care, almost like nursing home care, but they may not qualify for a skilled nursing facility or nursing home. So being able to do that respite type care, seeing people more frequently, having the nursing care available for folks, I think that there are some respite availability in Chicago, but that really needs to
limited. Yeah.
That really needs to expand. The other thing I think that we talked about before is, we as healthcare providers are only there for a limited number of hours. The shelter staff are there 24/7. Mm-hmm. So how can we support the shelter staff? How can we help with de-escalation if things kind of get loud in the shelter, for example? How can we help with trauma issues, both with our patients and with shelter staff? So how can we really support the whole shelter staff system, I think, is going to be really kind of important. And I think that the other thing is, just realizing that with resources, we can house people quickly.
Right.
If we have the resources, if we have the supports, people don't have to remain in shelters. They can be in large congregate shelters. They can be in the home that they would like with supports, and that includes social support. We had several people who during COVID went into an apartment, but then they came back to the shelter because that's where their social connections were. I had two people die of two people die of Omicron because they had their own apartment, but they came back to the shelter because they were missing their buddies. And they caught Omicron and they died, unfortunately. So we really need to look very carefully of how do we help with spiritual supports? How do we help with social supports? How do we create a home, not just a house?
Right.
So those types of things I think are really important as we move forward.
Wonderful. And to wrap up, one question for you would be that the last question for you would be, what would you want policymakers or the public to know about supporting this work?
Yeah, I think that housing is very important. It's affordable housing is very important. But, when we talk about permanent supportive housing, we cannot forget the supports.
Absolutely. So
we need permanent housing. We need permanent housing, but that middle word kind of gets defunded sometimes. We need to make sure that persons have the support to maintain that housing. Otherwise, it's going to be super expensive to have people cycling through different places all the time. So they will really need the behavioral health supports, substance use supports, the medical supports, the social supports, the spiritual supports that really make a community, to really make a beloved community. Right. How can we make a beloved community? And I think that's, those types of things are possible. We showed it during COVID, we showed it we could protect people from COVID and protectively house them, improve their health, and get them housed. We were able to show that during COVID, and we can do it. We can keep on doing it. We can keep on doing it, and I think that would be the important message: is don't forget the supports when we talk about permanent supportive housing.
Yeah, kind of ties back into earlier in the conversation, and you mentioned those things those interventions, those resources that make housing a home.
Yes,
right. And it's when people start to feel as though they have a home.
Yes,
is when you'll start to see kind of the fruits of the labor here. And the success of people staying housed and
Yes.
not re-entering in the cycle of homelessness.
Right.
Yeah.
And that word spreads, so the word on the street spreads. That's one thing I was going to say too, is that, you develop relationships with your clients, patients, the same thing. So we see people on the street, oh, I'm doing great, and that spreads to other folks to give folks hope.
Yeah, absolutely. Well, Tom, thank you so much for your time. I want to thank you and your whole team for all the wonderful work that you do, the life-saving work, all the advocacy that's happening. Honestly, a lot of times kind of behind closed doors. There's not a ton of awareness of this program, but it's so critical and so important. So thank you to you and, again, for the Lawndale team for stepping up to the plate.
Well, thanks for the opportunity.
Absolutely.
All right.
Thanks.